I'm going to give one or two examples, depending on time, maybe three examples of cases that we have seen in the first trimester that has feed anomalies, and try to draw some conclusion or draw some inference from there. All right? Okay, there are 6 cases now here. I think I'll just pick a few cases first. This is a first trimester anomalies case study of a 40-year-old Chinese, grafted 3 para-1 and 1 previous IUD, 1 previous brighted ovum. And at the dating scan was 9.4 weeks. That means this lady CR is reasonably early. And in my place of practice, if you come before 12 weeks, we'll catch you and give you an appointment of first trimester screening. And at our first trimester screening, apart from calculating the risk of the aneuploidies, we also have a look at the structures in the standard planes in our checklist. All right, and well, the crown rump length was 56, the NT measure 2.3, sound quite normal to me, except that there's a mass noted protruding from anterior abdominal wall, about 1.3 to times 1.3 mm, all right? And she was offered invasive procedure because the risk for all the trisomies in the calculation were high. And if you notice in FTS, if you have omphalocele and you include that in the risk calculation, and if it is about 11 weeks, the program will tell you that, well, they are not going to increase the risk, you calculate again next week. I'll tell you why. There's a good reason. The first time I was quite surprised when I entered omphalocele and they didn't increase the risk for that case for a woman that is 11 weeks pregnant. Although the CRL is more than 45 and they would accept that as still physiological. So this at 12 weeks is quite obvious to most of us. There's an omphalocele. It's quite a big thing. It's as big, if not bigger, than the abdomen circumference, with the vessel going in to the middle and the umbilical cord coming out from on top of the sac. So this shouldn't pose any problem to anyone. If you have been doing scans at second trimester, it looked just like second trimester omphalocele. This is an axial plane. Look at that thing there, and the 2 hands resting on it comfortably, like holding a pillow there. And this is the longitudinal axis from left to the right side, passing through the midline with the omphalocele bouncing. All right, at about 14 weeks, usually we do a cardiac scan. In my setup, if the nuchal translucency were high, if the nuchal thickness is thick, or there's any abnormality in the structure, we rescan at about 14 weeks, and we pay particular attention looking at the heart. That, in our setup, is called a cardiac clinic scan. So, and given another appointment to scan at 20 weeks, and to see the pediatric surgeons so that counseling on the background of the information and experience from the pediatric side can be given to the patient, so that the patient can make an informed decision on what they want to do. This is at about 14 weeks. You can appreciate that it's obviously much clearer than the 12 weeks. Just 2 weeks make a lot of difference when you're looking at structural abnormality. And if you see an omphalocele in the first trimester, take notes. Try to differentiate whether the liver is inside or not. If you don't see the liver inside and you see only intestine inside, apart from offering a karyotype, you can reassure the patients that the majority of those omphalocele with only intestine and no liver inside will return to normal by 20 weeks. So look at the 14-week scan, look at the heart. You can see a 4-chamber and 3-vessel view very clearly, whereas at 12 weeks, you're just guessing most of the time. But I suppose I must not be guessing too much. If you can see from downstairs, Can you see the 4-chamber heart and 3-vessel view? It's rather obvious, yeah? So that is the reason why we even bother to ask a patient to come back 2 weeks. From 12 weeks, we repeat a scan at 14 weeks, because at 14 weeks, we find that a 4-chamber heart and a 3-vessel view are satisfactorily seen in most of the cases. So this is a routine 20-week scan. The omphalocele is still there with the liver, with the intestine. No obvious ascites or bowel dilation. Single umbilical artery. Bilateral uterine notching seen. Standard deviation score of the abdomen circumference is -6, but that is very, very common for omphalocele. And umbilical artery PI is a little bit high. And CVS came back, result as 46XY. All right. And for counseling purpose, we did a 3D just to talk to the patient, say this is quite a big thing, although it started as 1.3 mm, but when a baby is only about 6 cm, 1.3 mm is quite something. So this is a proportion of the size of the omphalocele that we talk to the patient. Well, what is omphalocele amongst the rest of fetal abnormality in the first trimester? So I used to think that the first trimester you can't see many of the major defects. But the truth is, there's a Singalaki's paper, just came out last month from Fetal Medicine Foundation. 1/3 of the abnormalities that you see at 20 weeks can always be seen in the first trimester, 1/3. And a bit more than 1/3 is very variable. Sometimes you see them, sometimes you don't see them, depending on which system you're talking about. There's a certain percentage to them. And there's about 1/4 of the abnormality that you can see in 20 weeks you can never see in the first trimester. So what are they? So if we are talking about omphalocele, it belongs to the group that always detected in the first trimester. Remember I said about 1/3 of the abnormality that you see at 20 weeks, you can always see in the first trimester, and omphalocele is one of them. The rest are cranial, holoprosencephaly, gastrocysts, megacystis, and body stalk abnormality. The prenatal diagnosis issue, February issue this year, is one issue that you must have, because every single chapter, every single article is talking about fetal anomaly in the first trimester. All right, so it's depending on the crown rump length. Remember, I told you that at 11 week, the omphalocele is taken as, well, sometimes can be normal, but when at about nearer to 13 to 14 weeks, it gets rarer and rarer to be 1 in 2,000. Right, 1 in 100 is still taken as quite common. 1 in 2,000 is clearly uncommon. If you have a liver inside, then it's, well, 1 in 3,000. If you've got a liver inside, you always find the omphalocele present at 20 weeks. Whereas in the omphalocele with only bowel, 90% of them would have disappeared by second trimester. So you see omphalocele at the first trimester, you have more information that you can tell the patient now. I would prefer to go to case number 5 now, and then we'll come back to other cases. Remember, we say that about 40% of the cases, FA cases, fetal anomaly in 20 weeks, can be seen in the first trimester. This is one of the examples, although you may be surprised. 37 years old Japanese lady, at 11 weeks, came to us and scheduled for for first trimester screening. The appointment was given 2 weeks later. The crown rump length, nuchal thickness is a little bit thick. Nasal bone is seen. And at 13 weeks, stomach appears slightly high in position, heart slightly deviated to the center of the chest. Heart slightly deviated to the center of the chest is something that you sort of feel it, you didn't measure it, it looks as if it's a little bit more to the center. Watch out for diaphragmatic hernia. The risk is 1 in 200 for trisomy 21, 1 in 1006 for trisomy 18, 1 in 1009 for trisomy 13. Of course, then she is offered karyotype, and this is what we see. All right, this is the chest circumference, the chest, and that is the stomach, and that is the heart. When first looking at it, we didn't know that the stomach is the stomach, but after going through, excluding other abnormality in the chest, and in the first trimester, this is a case of congenital diaphragmatic hernia that is diagnosed. We decided for CVS. That is before CVS, the stomach is down there. The chest is the heart is displaced to the right side of the chest. The follow-up showed that, well, essentially what we find in the first trimester is still there at about 16 weeks, and the karyotype is normal, and that is our routine scan that we schedule her for. So that you can see that, well, it's pretty different from what you would expect at a normal fetus in the 20 weeks. Let's have a look at the video. Like Gary DeVore was saying just now, if you try to look at an ultrasound picture without a video, half the time you may be wrong. Yeah. So you can see that the four-chamber heart and the outflow tracts are there, but it's all pushed to one side from the diaphragmatic hernia. So this is a second category. The first one, omphalocele, belong to the category that always detected 1/3. This belong to that 40% that sometimes detected. Diaphragmatic hernia, 50% of the time, if you can see a diaphragmatic hernia at 20 weeks, it was there in the first trimester. That's exactly what happened to our neurotube defect cases. We went back to look at our first trimester. We discovered in the past we have missed a lot of open spinal bifida in the first trimester. So the next time you do a FTS, look at the fetus a little bit more carefully. You may be surprised that you may be able to diagnose 50% of the diaphragmatic hernias which present itself at 20 weeks. And this is a big database, and that paper is for singularity in a prenatal diagnosis. All right? I do not have postmortem to offer. At 17 weeks, they opt for termination of pregnancy. Let's go to the heart. As I said, fetal abnormality in the first trimester, we divide to 3 categories to make things more interesting, to make it a little bit more to deliberate. This is a case of the heart. And yesterday when I was giving the first trimester fetal abnormality lecture, I was saying that the heart has to be a separate lecture. But I'm not trying to give a whole lecture on the heart, but you may appreciate that after this, that maybe the heart in the first trimester is as interesting as a heart in the second trimester, as challenging. 31 years old, Chinese, primary gravida, came to us early and counsel for first trimester screening. So at first trimester screening, there's a crown rump lens. The nuchal translucency is slightly on the thick side for this crown rump lens, and the risk is calculated as low risk for trisomy 21, low risk for trisomy 18 and 13. But the NT thickness, 2.7 for 72.4 crown rump lens, is on the dot 95th centile. So all babies in my center that has an NT that is 95th or more or thicker would have another screen with specific attention for the heart. It's called a cardiac clinic. We do that about 14 weeks. That is a slightly thick nuchal. So at about 15 weeks, 14.6 weeks, we had have a look at the heart. And we discovered that it's actually much worse than that. It looks very much like a right isomerism, two of which example I gave you just now in an earlier lecture. Stomach on the right side, and stomach is very near the spine. Asymmetry ventricle, if you have AVSD, that's asymmetry, is more likely isomerism with a normal chromosome than a Down syndrome, which has a balanced AVSD. And there's one big, huge outflow tract, and the IVC is on the left side instead on the right side, and it's on the left side anterior to aorta. You will see this kind of combination with a grossly terrible-looking, complicated heart. You think of isomerism. So isomerism in other people's lecture, they'll tell you, well, never need any karyotyping. But in our center, if there's a fetal abnormality, structural abnormality, we routinely offer karyotype. Refer to cardiologists for counseling because that is a really complicated looking heart. And we want their experience to give the information, or want them to give the information to the patient rather than firsthand, rather than going through us, which we may be biased. All right, stomach is very near the spine and on the wrong side. And there's the heart. Does it occur to you this is a very funny looking heart? You don't see the four-chamber view. And in the outflow, you see one big outflow. And at that time, we thought that this is the IVC. But when you go back to have a look again, if this is the aorta, the IVC doesn't come parallel to it through the diaphragm. The IVC will come this direction. So on retrospect, this is probably the azygous continuity. That is a picture very highly suggested of isomerism. All right, there's a funny looking heart. For heart, you must always look at the video. There's only one valve there, one big AVSD with the atrium almost looking like one because there's a big ASD down here also. And the outflow tract is on the wrong side and one big outflow tract that you can see. Such a case in the past, we always put down 20 years. 20 years ago, we just put down as complex heart. Actually, you would, nowadays, you should actually suspect that it is isomerism. The same thing, there is an AVSD going through, and the big vessels that is coming out, this video is now not working. That's okay, that's okay. Earlier on, never mind, forget it. Let's go to the next slide. At 19 weeks is a routine scan, the time for routine scan. It shows that there's one big outflow tract with right and left pulmonary vessels from the beginning part of the common trunk, which was not showing on the clip just now. IVC appeared to enter the left-sided atrium, left side of atrium. Because the atrium is a big ASD and it looks as if it's a common atrium. So we won't know the left or the right atrium. Pulmonary artery veins demonstrated to enter right side of the atrium. As expected, the chromosome is normal. So all your complicated, horrible looking hearts, if they are isomerism, they are always normal in karyotype. So nearer 20 weeks, the heart is much, much clearer. You notice the back of the atrium, not here. The back of the atrium at the beginning of this clip is very smooth. So I suspect that maybe the pulmonary vein that we mentioned just now were not actually entering the left atrium, but it could be a case of total anomalous pulmonary venous drainage. There's AVSD. At the outflow tract, sorry, this video is so small. At the outflow tract, this outflow tract, you can actually see that arising from this common trunk are two pulmonary vessels. I'm afraid I can't demonstrate that. All right, let's skip that. All right, so at 17 weeks, we confirmed what we suspect earlier, and the couple decided for termination of pregnancy, but they are not keen on postmortem. I do not know whether it's the same down here, but I do know my friend in Shenzhen is very successful with getting consent for postmortem. And for a place like ours, if we are interested in studying congenital heart, and if we can't get our pathologists or our patients to do postmortem, it's a big disadvantage. All right, I say that heart is important on its own score in the first trimester. This is the finding of what the Fetal Medicine Foundation's publication is stating. Major heart defect, you can discover most of them in the second trimester. Only 1/3 of them you can see in the first trimester, because that is the size of the heart in the first trimester. Very small, it's as big as your 10-cent coin. Yeah? And a tetralogy of Fellows, even after laboring tetralogy of Fellows, you may not be able to make out tetralogy of Fellow unless you are very interested in congenital heart diagnosis yourself, and you've been doing this for a long time. All right? That is the overriding aorta. Up with a small pulmonary vessel. And this is more or less what they are expecting. Well, they can go to this issue 31 and find out this paper from Singalati. They screen 45,000 mothers and 44,000 down here, finding at 11 to 13 weeks. And only 28 is discovered to have a heart defect at the first trimester. And the second trimester, twice as many. That's why we were saying that only 1/3 of the number that you can find at second trimester, you can diagnose in the first trimester for congenital heart. So that's more or less what you can expect for yourself if you are interested in fetal abnormalities in the first trimester and you want to give your patient the best chance of having an early diagnosis of the congenital heart. It's one of the hardest things for prenatal diagnosis. The heart itself is a big challenge to most of us. So if it's difficult, what do? Do you give up or do you find something else to do? Well, sometimes I do, but there are hopes of capturing a captive audience for you. Actually, the fetus is not audience, actually. Never mind. So in those cases with major heart defect and those without major heart defect, there are telltale signs which we are already looking at, but we are not comparing them. So it says that if you have a fetus that has a congenital heart, 35% of them would have thick nuclear translucency. And 5% of the normal fetuses would have thickened translucency. That's obvious, isn't it? By definition, thickened translucency meaning 95th centile, right? Above 95th centile, so you get about 5% down here. But if you go to a population with a major congenital heart, it's 35%. So if you understand the calculation of likelihood ratio, which is a weightage, the density of chances of getting a disease, then you know that if you see a thickened nuclear translucency, you have about 7 times chance of having a congenital heart. So next time when you see any fetus with thickened nuclear translucency, look more carefully or do what I do. I see them at 14 weeks, again looking at the heart and calling that a cardiac clinic so that your administrator won't be chasing after you and saying that you're doing something for free, all right? So if you're interested, you do it for free. If you see someone with a thick nuclear translucency, or you see, let's say if your clinic is a has resource constraint, then you see only those fetuses with nuclear translucency that's more than 3.5, which is a 99th centile or NT. Then you would have about 10 times the concentration of having congenital heart fetuses from your first trimester screening. If you look at this from another angle, of the whole population, in the last 2 years, of the whole population in my center, of the fetuses with nuclear translucencies that's more than 95 centile, is about 5% of them has congenital heart. 5%. The normal incidence of congenital heart is 8 per thousand. Even if you put it as 1%, is 5 times more. And if you look at it this way, that all the fetuses with maternal diabetes should have a specialist to scan, you are looking at a percentage of fetal abnormality much less than 5%, and it already justifies specialist sitting down there doing a specialized list. So on that count itself, you can always justify doing your cardiac clinic for all the babies with the nuclear translucency that's more than 95 centile. That means if it's too thick, or if you've got resource constraint, nuclear translucency that's more than 3.5. And then if you have to justify to the administrator, you quote these figures. All right? But the truth is not quite there. But if I were the administrator, I will ask you, if you exclude all your aneuploidies, all the trisomies, then you don't have 5% of your NT population having congenital heart. The answer to that is actually, the truth is that when we calculate out the figures, if we take away the aneuploidies and we only put the euploid, so euploid thick NT has about 2.5% of them having congenital heart. That compares about to 0.8% in the background population. Is still quite a sizable thing to justify a special clinic. Well, as I showed you the slide earlier, in the other lecture, I usually do things on impulse. I don't ask for permission. So if you want a cardiac clinic, if you're interested in that, find your own justification and just do it. All right? So the other, one thing is a nuclear translucency. If it's thicker, you've got higher chance of having congenital heart. Look at them carefully if you are looking for heart abnormality. And if you have ductus venosus abnormality in the first trimester, also look at them carefully, because a normal ductus venosus Doppler would have reduced your chance of having a congenital heart abnormality. On x-axis is this nuclear translucency. Delta is different from expected. If your delta NT is 2, meaning that for that CRL, if you're expecting 1.5 mm NT, you got it for 3.5, then it's delta NT of 2. If your ductus venosus is normal, your risk of having congenital heart drops back again. But if you have a DV that's abnormal or tricuspid regurgitation that is detectable, then again, the congenital heart incidence increase. So, 33% of major heart defect, which can be picked up at 20 weeks, will be visible in the first trimester. And the rest down here are the incidence of those fetuses with NT that is thicker than 95 centile, thicker than 99 centile, and other ultrasound findings like DV and TR are on this side. I think that itself justified you to get that particular article from Singalati. Well, are we happy to look at other things? This is a duplication, so I don't think we need that. Let's have a look at this one. 31 years old Malay lady, multiparous, came to see us early, has diabetes and GBS colonization. FTS is scheduled for her. At FTS, the crown rumble 63, NT of 10. NT of 10 meaning there is a very high likelihood of a baby dying, and of course, tens of percent of having other abnormality like cardiac and other FA. Very high trisomy risk. And on the physical structure itself, we see micronatia. That's what we see on the profile of the face. That is micronatia. At the first trimester, these seem to be normal. That is a thick NT. It is so thick I can't recognize the picture myself. It's a very thick NT. NT of 1 cm when a baby is only 5 or 6 cm is a lot. So 4-chamber heart and outflow tract are grossly seen because the mother isn't very accommodative. Offered karyotype. That is a gene. That is a heart. With a thick NT, obviously you have to look at the heart, but it doesn't look like there's something that is very obvious to us. You saw the stomach just now. That is on the left side. The heart is pointing on the correct side. 4-chamber view looks grossly normal. The outflow tract will be coming out. There's the outflow tract. Nothing very, very exciting at that moment. At 20-week scan, the same receding gene, no other abnormality seen as predicted at 14-week scan, normal karyotype. That is a receding gene, despite a measurement of mandible being normal. I think the mandible measurement isn't that useful for micronatia in this case. The shape of the mandible is a little bit strange. And she delivered normally of a girl, good Apgar score, 3.5 kilogram. And this is what is recorded in a geneticist finding. And it is a case of a syndrome which we're not too sure what it is. The chest X-ray shows 7 pairs of ribs. As you know, Down syndrome usually is described as a higher incidence of having 13 pairs of ribs, but these are 7 pairs of ribs. Some strange finding on the bones and hypoplastic mandible with loss of mandibular angle. That is what we saw anyway at about 20 weeks, in keeping with micronatia. Reversal of cervical lordosis with widening of prevertebral space. So that is a funny looking neck. It should be this way, but it's this way. There's a chest X-ray. You can probably count the ribs, but the gaps are really, really big in between the ribs. And this is manifested in the first trimester as a thickened NT and a mid-sagittal profile as micronatia. Well, I think that's all I have to say. Is there anything you want to ask? Any question before Dr. Hyatt comes back?
Any questions from the floor?
Anything about first trimester that you want to know, which I may be able to answer? You don't have to confine to asking me about fetal anomalies in the first trimester. You can ask me things that I talked about this morning, about the experience in Singapore if you want to. How many of you practice first trimester screening? First trimester screening? In China, is there many centers practice first trimester screening? Because I see less than half, and most of the people that raise their hands doesn't look Chinese to me. Is it a logistic problem, or is it a case of evidence not strong enough for you to want to practice first trimester screening? For the Chinese, is the evidence not strong enough, therefore the authority is not convinced enough, or some other reason that you do not want to do first trimester screening yet? Not prepared enough, or logistically difficult? No answer, no questions.
Could it be the problem of the ultrasound expert? It's easy to perform the biochemical test, but you need someone to do the scan. What I guess?
Yes. There are two answers two things I want to touch on there. I have a Chinese friend who is leadership in one hospital. When we talk about first trimester screening and nuclear translucency, the impression is that 门槛太低, that means it's too simple, it's too easy. But I hope that after these 3 days, these 2 days and including tomorrow, you understand that the requirement and of the measurement of nuclear translucency is actually quite stringent. So the first thing is that when you say that biochemistry may be easier, yes, biochemistry may be easier to standardize. You pass a standardized solution through the machine and then read from the piece of paper where the standardized machine comes from. You calibrate a machine to that, and you can be more or less assured that it's reliable for measurement. Whereas for nuclear translucency, like my lecture yesterday, even in my hospital, where those among the sonographers who are doing first trimester screening, they did not realize, but I show it with evidence, they did not realize that they do not agree with each other well enough. The degree of agreement is only 0.6, which is just so. And after training, that's why it's just not like machine. You don't train a machine. You pass a standard solution through and then you calibrate it, that's it. Whereas for nuclear translucency measurement, you need to calibrate your sonographers. You calibrate sonographer by specialized training and also certification accreditation by the Field of Medicine Foundation, which I think is a little bit reasonable to say that it's a little bit more difficult than just to calibrate your machine.
Yes. May I ask back to this lecture? So for those nuclear more than 95%, you offer a cardiac scan at 14 weeks.
Yes, in my setting, I scan them again at 14 weeks.
I think it is a good idea, but due to the resources.
Yes, it's a problem with resource.
In a public hospital.
Yes. Well, as I said, like the cartoon I showed earlier on, a lot of time when I find evidence to justify to do things, and not my whims and fancy, but evidence on things that I read and from friends and from meetings I attend, I just do it. I just open a cardiac clinic and then just schedule appointment on it, and most of the time your administrator won't know. By the time they find out, you got enough evidence to tell them that this is a very good practice.
Yeah. It's easier because you're the boss.
It's quite easy if you are the boss, blue-eye man or right-hand man.
If no further question, we'd like to thank our Dr. Yo as usual.
There are structures that is much easier to see or more successful to see at 12 weeks and 14 weeks than 20 weeks. Things like looking at all 4 limbs and counting fingers. It's easier at 14 weeks than 20 weeks. Yeah, because the baby turn around, the baby always put a hand in front of the face. You can see them. And things like palate, if you want to look at a palate in a volume and turn and look at the palates, you have advantage at 14 weeks that there's no shadowing. Whereas at 20 weeks, you look at the palate, there's a lot of shadowing and at the two sides and look as if it's cleft. So there are certain advantage at 12 weeks that you can see things, certain anatomy is seen better at 12 weeks than 14 weeks.